Thank you, Bhatia sir, and good morning to everyone. Wilson's disease in children is our topic, challenges and development, and this is the clinical grand rounds from our department. So before I hand over the mic to my residents, I'll just tell you a brief overview that what we plan to show is a brief introduction of what Wilson's disease is, how we diagnose and what is the therapy overview brief, a few clinical case vignettes which will help you understand the cases better. And then we have the departmental experience and what research we are doing so far, and some future directions. So with this, I hand over the mic to Dr. Orgo.
Thank you, sir, and a very good morning to everyone. Wilson disease is a genetic disorder of copper metabolism which is transmitted in an autosomal recessive manner. Its worldwide prevalence is in 1 in 10,000 to 40,000. It is caused by mutations in ATP7B gene, which is required for normal biliary copper excretion. And so far, more than 600 mutations has been identified worldwide. In Wilson disease, thus there is excessive of copper which gets distributed in liver and many other extrahepatic organs. Thus, it is a multisystemic disorder with a myriad of clinical presentations and hepatic manifestations around 50% of children. As we understand, in the pathogenesis of Wilson disease, the dietary copper gets absorbed in the intestine and then bound to plasma, albumin, and transcorporin. It reaches liver. Within liver, this copper gets incorporated into the apocellular plasmin with the help of ATP7B. It also helps in the normal copper excretion in the bile. In Wilson disease, these are abnormal, so there is excessive free copper which causes damage to the liver and other organs like brain, kidney, eyes, and RBCs and causes various clinical manifestations. Hepatic and neuropsychiatric manifestations are the two major clinical manifestations, along with Kaiser flushing in the eyes. As we can see in the graph, in children less than 10 years of age, hepatic manifestation is the predominant manifestations, while as in patients more than 18 years of age, neurological manifestations predominate, showing a clear age phenotypic effect at presentation. There are many minor presentations like renal tubular acidosis, Coombs negative hemolytic anemia, sunflower cataract, and premature osteoporosis and osteoarthritis. The hepatic manifestations of Wilson disease can be in around 3 to 40% of the patient. We can have asymptomatic manifestations like incidentally detected hepatomegaly, persistent elevation of liver enzymes or fatty liver, or it can be detected only on sibling screening. Acute hepatitis like picture can be seen in 10 to 25% of the patient, acute liver failure in 8 to 20%. Acute and chronic liver failure is also common, but the commonest presentation in our setting is the decompensated cirrhosis in around 35 to 60% of the patients. Chronic hemolysis can give rise to cholelithiasis also. Now, how do we diagnose? In the presence of hepatic manifestations, we found Kaiser flushing on slit lab examination in the eyes. If there is low serum ceruloplasmin and elevated 24-hour urine copper, then the diagnosis of Wilson disease is confirmed. Serum ceruloplasmin value of less than 20 mg per deciliter is suggestive, and less than 10 mg per deciliter is very strong indicator of Wilson disease. 24-hour urine copper more than 40 microgram is suggestive, and more than 100 microgram per is all definitive. Liver histology, liver copper estimation, which is more than 250 microgram per gram dry weight, the history of affective sibling, and extrahepatic features, extrahepatic manifestations are contributory to this diagnosis. Genetic mutation is confirmatory, but it is cumbersome and not mandatory, as we have told earlier that around more than 600 mutations are available. Now coming to the therapeutic overview, oral chelation therapy is our mainstay of therapy. Dietary copper restriction is usually practiced in the first year of treatment. We provide supportive care in the form of endoscopic screening for esophageal varices, immunization for hepatitis A and B, and sibling screening, which is mandatory. liver transplantation is contemplated in the setting of acute liver failure or progressive disease. We have three medications available for treatment. Zinc, which is actually not a chelator, rather it displaces the dietary copper, and it has shown poor efficacy in hepatic disease. Then there is D-penicillamine, which is a systemic copper chelator and is a good affinity for copper, as is evident from this K value 2.38, which is an affinity indicator, and it has shown an efficacy of around 90% in hepatic diseases and is relatively affordable. Triantine, which is another chelator, has shown a similar efficacy of 80 to 90% in hepatic diseases, but it is expensive and it has an issue of shelf life and require storage in refrigerator. Considering all this, D-penicillamine is our chelator of choice in all the liver phenotypes. Zinc is usually reserved for pre-symptomatic patients who have normal biochemistry and usually are detected on sibling screening. Triantine is reserved for those patients who are intolerant to D-penicillamine. Now we face certain issues during management of hepatic ulcer. There is no consensus so far whether single or dual chelation is best for hepatic ulcer disease. This chelators takes at least 6 to 9 months for optimal hepatic action, so we require a lot of patience for clinical response, and after that we need to have an optimal window for liver transplant referral if required. Compliance is a major issue. The cost of the medications and the timing. Most of the medication they recruited should be taken more at least 1 hour prior or 2 hours after meal. The storage of in refrigerator in case of triantine, and adolescents don't like to take many medications. There is no therapeutic drug levels are available for monitoring, and low serum albumin as seen in cirrhotic patients can lead to poor drug delivery. And many complications of the Wilson disease can mimic that of drug side effects, like cytopenia of hypersplenism may mimic cytopenia due to bone marrow suppression of oral chelators. The tubulopathy or nephrocalcinosis due to Wilson disease can mimic that of glomerulonephritis due to chelators, and the progressive neurological involvement can mimic the paradoxical worsening after starting chelators. Now, I would like to show few cases to elaborate further. I invite Dr. Sridhar to show the next case.
Thank you, Dr. Varghya. Good morning, everyone. Today I'll be presenting my first case, a 11-year-old boy who had presented with poor scholastic performance and drooling of saliva for the last 1 year and had jaundice and ascites for 6 months. This child did not have any encephalopathy, variceal bleed, cola-colored urine, and did not have any prior history of sibling death. On examination, a Kayser-Fleischer ring was apparent to the naked eye. There was differential enlargement of the liver. There was splenomegaly and handwriting changes. On investigation, the child had deranged liver functions in the form of low serum albumin and elevated liver enzymes. The hemogram was suggestive of hypersplenism. Ascitic fluid analysis had shown a high serum ascites albumin gradient, which was suggestive of portal hypertension. Upper GI endoscopy had shown small esophageal varices. Further etiological workup had shown a Kayser-Fleischer ring on slit lamp examination, a low serum ceruloplasmin, and an elevated 24-hour urine copper. With this, a diagnosis of neurohepatic Wilson disease was made, and the child was started on chelation with D-penicillamine. As can be seen, over the next year, the liver enzymes had normalized, the KF ring had disappeared. Gradually, neurological symptoms had also improved over the next 4 to 5 years. Now, the child is on follow-up for the last 14 years and presently studying in BA final year and doing well. So, as apparent from our case, good compliance, regular follow-up and surveillance can result in a good outcome. Hepatic resolution took around 1 year and neurological improvement took 5 to 6 years in this child. So, the long-term outcome in both hepatic as well as the neurological disease is rewarding and it can result in a gainful living. Even in the world literature, as shown, the clinical and biochemical improvement can take place in around 6 months' time. However, the synthetic functions sometimes take up to 10 years to normalize.
The neurological improvement is much slower, and a plateau is reached only after 2 to 3 years of therapy. This is a study by the Euro-Wilson Consortium, which had described the efficacy and safety of oral chelators. They had followed 467 children, 326 of which were treated with D-penicillamine, and 141 were treated with trientine, for a median follow-up of 13 years. So as seen, the efficacy of the chelators in hepatic Wilson is around 90%, and in Euro Wilson around 60%. And there was no significant difference noted. So this is a study which was published by our department, where the effect of chelation therapy in pediatric Wilson disease was seen. And this was published in Journal of Hepatobiliary and Pancreatic Sciences. So 111 Wilson disease patients were followed up, and the median age of onset was around 9 years. The duration lag between the symptom onset to diagnosis was around 2 months. Around 60 to 70% of our patients had presented with jaundice, hepatosplenomegaly, and ascites. Hepatic encephalopathy was seen in around 20% of the cases. Neurological and renal involvement was seen in further 10% of our children. So the predominant mode of manifestation was as a decompensated chronic liver disease, and further acute on chronic liver failure and acute liver failure constituted another 15% each. So as shown, a severe disease presentation was seen in around 80% of our children, and 19% of whom had a mortality. So this is a busy slide wherein we show the follow-up of our children. Out of the 111 children, 65 cases were analyzed who had a follow-up of at least 9 months duration. And out of these 65, 54 children were on therapy with D-penicillamine, and another 11 children were on therapy with D-penicillamine and zinc. And as seen, we followed up the children for a median duration of 3.5 years, and a favorable outcome was seen in 70% of our children, and disease progression was seen in 30%. Around 10% of our kids had drug toxicity, which required change in the chelator. Now coming to another interesting case, this was identical twins. The twin A had presented at 10 years of age as a decompensated liver disease in the form of ascites. Child had hepatosplenomegaly on examination. A case of Leisure ring was apparent. There was a low serum ceruloplasmin and an elevated 24-hour urine copper. With this, a diagnosis of Wilson disease was made, and he was started on D-penicillamine. On screening the sibling, he was also having a hepatosplenomegaly. This child too had a case of Leisure ring. There was low serum ceruloplasmin and an elevated 24-hour urine copper. He was also diagnosed to be Wilson and started on D-penicillamine. So this is a picture of the two of the twins, and as seen, the twin A, who was more affected, you can see that he is shorter in height. So these children were followed up, and the twin A, due to poor compliance, he was not getting adequate chelation, and preferentially the parents were giving the chelator to the twin B, who was less affected. And when we followed him up, the twin A had worsening of liver disease and had new onset neurological features in the form of dystonia. With the help of neurology department, we had decreased the dose of D-penicillamine transiently and started other supportive management. Gradually, the dose of D-pen was then increased. So in the next 6 to 8 months, the child had improvement in the neurological functions. However, there was progressive hepatic deterioration. And as we speak, the child is readmitted with recurrence of ascites and an ascitic fluid infection. And the twin B, as we can see, had a progressive improvement in his state. So the message from this case is that sibling screening is essential, as early initiation of therapy can result in better control of the disease. Genetically similar individuals may progress differently, and compliance issues can cause setbacks, and these setbacks are not always reversible. In our particular child, the compliance issues took place because of financial constraints, and as we can see, therapy with D-penicillamine for each sibling cost around 1,500 rupees per month. The sibling screening protocol that we follow is all the siblings of the proband are examined. If a mutation analysis is available, the mutations will be looked for in the sibling. And if it's not available, a clinical examination is done followed by liver function test, and then we do slit lamp examination for case of fissuring. We get a serum ceruloplasmin and 24-hour urine copper. If there is ambiguity, we further go ahead with a liver biopsy for liver copper estimation. Our departmental data about sibling screening. So we had around 137 probands, and these probands had around 263 siblings. 48 of these siblings had died prior to presentation to our institute. So the remaining 215 siblings were screened, of which 203 were normal and 12 were affected. So this yielded around 8.7% of the cases. So further, if we take into consideration the entire affected, the 48 prior deaths as well as this 12, so it constitutes to around 23% of the total siblings, which is confirming to the autosomal recessive pattern of Mendelian inheritance seen in Wilson disease. In the world literature, as we can see, the sibling screening yields around 10 to 16% of the cases of Wilson disease. With this, I would like to invite Dr. Neeraj to present the further cases.
Morning everyone. Our next case is a 9-year girl who presented to us with complaint of jaundice for 4 days, ascites for 2 days, altered sensorium and cola colored urine. And on evaluation, child was found to have grade 3 hepatic encephalopathy. Her liver function test saw very high total bilirubin of 33.5, high AST as compared to ALT. AST was 318 and ALT was 36, and alkaline phosphatase was unusually low, 55. So in this scenario, where AST to ALT ratio is more than 2.2 and alkaline phosphatase to total bilirubin ratio less than 4, is suggestive of acute fulminant Wilson disease, which is evidenced by presence of KF ring and a very high 24-hour urinary copper of 2673 microgram. On further evaluation, the child was found to have Coombs negative hemolytic anemia, and additionally, she is also having acute kidney injury, which is evident by increased creatinine of 2.4. So we made the diagnosis of acute fulminant Wilson disease with acute kidney injury. Ideally, such patients to undergo liver transplant, but as there were no finances and donor for the same, so we started a trial of plasmapheresis along with chelation therapy as to buy some time for the liver transplant. We had given 6 sessions of plasmapheresis over next 11 days, and child had shown good response. Her encephalopathy, coagulopathy, and hemoglobinuria improved, and her hemoglobin was stabilized. The pediatric end-stage liver disease score decreased from 38 to 23 at the 6th session. So this child was showing good response, and on follow-up, she was continued to taking D-penicillamine with the proper doses and compliance, and showing improved liver function test. And we followed this child for next 3 years, and her AST, ALT, liver enzymes were normal. Albumin is normalized. There is no coagulopathy. INR is 1.2, and she is doing well. And this is how she looks at present at age of 12. She studies in class 8 with an average scholastic performance. Next similar case is a 10-year boy who presented to us with complaint of jaundice for 2 months and ascites for 2 months and cola colored urine. This child has no encephalopathy. His liver and function test also similar to the previous case, with very high total bilirubin and high AST as compared to ALT, showing AST to ALT ratio more than 2.2 and alkaline phosphatase to total bilirubin ratio less than 4. And this child also had Coombs negative hemolytic anemia with presence of KF ring, very low ceruloplasmin, and 24-hour urinary copper very high, 856. In this child, we made the diagnosis of acute fulminant Wilson disease with Coombs negative hemolytic anemia, and we advised for the liver transplant, and the parents were willing for the same, but they were trying to get some time for arranging finances and donor. So we had given a trial of plasmapheresis as a bridge therapy for the liver transplant. We had given 3 sessions over next 6 days, and child showed some improvement transiently, but later on his hemolysis was persisting, coagulopathy was persisting, and there was rising level of serum copper. So this child undergone liver transplant on day 11. living donor liver transplant with left lobe graft done on day 11, and child is doing well on triple immunosuppression. His recent liver function test is absolutely normal and child is doing well. This is how he looks at present. So message from these two cases, we should suspect a case of fulminant Wilson disease in setting of acute liver failure with clues from liver function tests like AST to LT ratio more than 2.2, alkaline phosphatase to total bilirubin ratio less than 4, and most of these patients present with the Coombs negative hemolytic anemia. Ideally, these patients to undergo liver transplant, but if liver transplant is contemplated, a plasmapheresis may act as a bridge for liver transplant. This is a case series of 10 patients of Wilson disease who presented with acute liver failure and undergone plasmapheresis between 2005 to 2013 and registered in the American Society for Apheresis Registry. And out of these two patients, only one patient survived with native liver, and 9 out of 10 patients underwent a liver transplant over the time. Similar history, a similar series by the Institute of Liver and Biliary Sciences also suggests that plasmapheresis may act as a bridging therapy to liver transplant and improve the 90 days transplant-free survival in case of Wilson disease presenting with acute liver failure. Now I invite Dr. Upasna to proceed further.
Good morning. I'll be presenting the importance of disease monitoring in case of Wilson disease. So what do we do when we get a patient on Wilson disease who has started on chelation therapy? We have three important things to look at. The first one is response to therapy that we see by clinical examination and yearly slit lamp examination, biochemical tests for the liver functions, ultrasound abdomen, and upper GI endoscopy. For assessment of the adequacy of treatment, we have 24-hour urine copper estimation and non-ceruloplasmin bound copper estimation. And most importantly, to look at the adverse effects, we have to do a proper physical examination to look for neurological worsening or skin changes, a hemogram to look for cytopenias, and urine examination to look for proteinuria. This is a picture which is showing Kaiser-Fisher link at the onset of the therapy. And subsequently, over a period of 1 year, there is significant reduction in the Kaiser-Fisher link as shown in the image. And also the literature shows that in about 30 to 80% of the cases, there is resolution of KF link over 3 to 5 years duration. Now coming to the side effects of D-penicillamine, we have certain adverse effects where a re-challenge with D-penicillamine is absolutely contraindicated. And these are aplastic anemia, glomerulonephritis, skin changes in the form of degenerative conditions, and acute hypersensitivity reaction. This is the picture of a child that we had who presented with acute hypersensitivity reaction and skin rashes after 7 days of starting D-penicillamine. Among others, we have neuropathies, connective tissue disorders, and pulmonary fibrosis. The only condition where we can consider a re-challenge is a paradoxical neurological worsening after starting D-penicillamine. Here we buy time and decrease the dose of D-penicillamine, and after the symptoms are controlled, we can start at a lower dose. The other would be GI disturbances in the form of dyspepsia. Now coming to the comparison between the adverse effects in case of D-penicillamine versus trientine. This was a study done by the Euro-Wilson group where they have done follow-up over a period of 30 years and shown that the adverse effects with D-penicillamine were 28, while as comparison to trientine, which was only 7%. Now coming to this case of a 12-year-old girl who was diagnosed as a case of hepatic Wilson, had presented to us with a new onset hematuria. On workup, her urine analysis showed a urine pH of 7. There was hematuria. The blood gas analysis showed a normal anion gap metabolic acidosis, and there was hypercalciuria. Ultrasound abdomen showed medullary nephrocalcinosis. At this point, we had taken opinion from endocrinology and nephrology, and with that, we made the diagnosis of renal tubular acidosis in a case of Wilson disease. Subsequently, the D-penicillamine dose was optimized, and the child was started on alkali therapy. About 2 months later, the child developed fracture of the neck femur. Again, we had taken opinion from endocrinology, and she was found to have low bone marrow density. And She was started on zoledronate, that is a bisphosphonate for the same. Later on follow-up, her bone mineral density is improving and liver functions have stabilized. Now, in contrast to the previous case, here we are presenting another case of a 17-year-old boy who was diagnosed as a case of neurohepatic Wilson and was started on low-dose D-penicillamine and zinc. 2 years later, this child developed decompensation in the form of ascites, which required increase in the dose of D-penicillamine. And the child was on regular follow-up. And 3 years later, on routine screening, he was found to have hematuria and nephrotic range proteinuria. At this point, again, nephrology consultation was taken, and they had advised for a renal biopsy, but in this child, renal biopsy could not be done as he had a coagulopathy. So with this, we diagnosed the child with deep-induced glomerulonephritis. So D-penicillamine was stopped and child was started on trientine. Subsequently, over a span of 6 months, the 24-hour urine protein has normalized and there is partial improvement in the liver functions. So now comparing these two cases, how do we diagnose deep-induced glomerulonephritis versus renal tubular acidosis? So deep-induced glomerulonephritis is due to immune complex deposition, and it usually starts after starting on chelation. Whereas renal tubular acidosis is due to direct toxicity mediated by copper on the renal tubules, and it can be there at the onset of disease or after starting chelation. A most important thing to note is the treatment. That is, we have to stop D-penicillamine in case of D-penicillin-induced glomerulonephritis, while we have to continue the same in renal tubular acidosis. Now, how to distinguish the two? For this, we have various tests, that is urine analysis for urine pH evaluation, urine for hematuria, proteinuria, and calciuria, a blood gas analysis for metabolic acidosis. An acidification test may be required in incomplete RTA, and we will have to do autoantibodies and renal biopsy for suspecting glomerulonephritis. Now coming to the next case, here is a 12-year-old girl who had presented to us with jaundice and ascites and no apparent neurological manifestation. And she was worked up and diagnosed to have Wilson disease. She was started on D-penicillamine. Subsequently, after 6 weeks, the child developed neurological deterioration in the form of change in handwriting and slowing of the movements. At this point, neurologic consultation was taken, and they had advised an MRI brain. MRI brain revealed hyperintensities in the thalamus and pons. So at this point, D-pen-induced paradoxical worsening was considered, and D-penicillamine was stopped. The child was started on zinc and trientine. Over the years, she had improvement in her neurological functions, and the LFT done 1 year later showed complete normalization. So what do we do when we have a case like this who presents with a neurological deterioration? There are two possibilities. Either it is due to the progressive disease, or it may be due to paradoxical worsening caused by the chelators. It is MRI is very difficult to differentiate the two based on MRI. The only supportive evidence that we can have is by doing a serum copper level, which is increased in case of paradoxical worsening due to D-penicillamine. As we go through the literature, we find that about 15% cases of paradoxical worsening due to chelators, D-penicillamine is responsible, while trientine and zinc can cause up to 5 to 8% of the cases. This is most commonly seen within 3 months of onset of chelation, and is the highest incidence is seen in neuro-Wilson, up to 50% of cases. So the strategy is to start at a low dose and goes very slowly. The incidence in neurohepatic Wilson cases is in up to 30% cases. In severe cases, it can lead to mortality, which goes up to 5%. Now coming to the next case, here is a 12-year-old girl who had presented with jaundice and decompensation in the form of ascites, and the workup revealed the diagnosis of Wilson disease. So this child was started on D-penicillamine, and over a span of 2 years, there was normalization in the LFT. She was on regular follow-up on our side, and 2 years later, she was found to have cytopenia. At this point, hematology opinion was taken, and a bone marrow biopsy was done, which revealed a hypoplastic marrow. So the child, the D-penicillamine was stopped, and the child was started on supportive management, and also later on cyclosporin and danazol was added. However, there was no response to this, and the pancytopenia was persisting and she had to be referred for bone marrow transplant. So how do we differentiate bone marrow suppression versus hypersplenism? We have to go for the basic investigations in the form of hemogram and reticulocyte count. And for the confirmation of bone marrow suppression, we have to do a bone marrow biopsy. The most vital thing to remember is that we should regularly monitor for cytopenias, initially, frequently, and later on at an interval of 3 to 6 months. Coming to the adverse effects profile in our departmental data, we have around 17.5% of cases who had adverse effects. And out of this, the majority, that is around 50%, was the neurological worsening after starting the chelators, followed by hematological adverse effects in the form of cytopenias in 28% case, and glomerulonephritis due to DPN in 20% of cases. Among the neurological worsening, we had about equal proportion of neurohepatic Wilson and hepatic Wilson, that is at 5 age. Also, there were 2 cases of asymptomatic siblings who had presented with neurological worsening. Now, I would invite Moinak sir for carrying forward the further presentation.
So good morning once again. That was about the clinical vignettes we had shown. What are the setbacks that we are having in India? So in about 2016, the D-penicillamine was not available for about 9 months. Every center almost had a lot of decompensation, mortality. Trientine is a very expensive drug that was not available till 2017. It was mainly being imported from UK and it was in the black market. Even now it is available, but it is cost prohibitive. As with every disease, the COVID pandemic hit us as well regarding drug availability and affordability in the last 1 year for our patients, affecting follow-up in research. Reliability of labs is a major issue in our country because all the tests are not consistently done in the proper way. In fact, just outside SGPGI, only about 10 years back, we had fake labs that were giving us wrong results of urinary copper for a long time. There is paucity of Wilson's disease support groups, and liver transplantation is still a dream for many of our patients. So to circumvent that, at least for the lab, the department in 2016 acquired the atomic absorption spectrophotometry. And in 2017, in-house, we started doing the 24-hour urinary copper and the serum copper. 1 year later, we started estimating the hepatic copper. And in 2019, now we are doing exchangeable copper, but only as a research tool in our research. So far in the last 15 years, we've seen approximately 150 cases, and Wilson's disease constitutes to be 20% of all our chronic liver disease 5 to 18 years referral. And over time, we've had a good number of publications, been a part of consensus guidelines, and also presented abstracts in conferences. So this is the paper that we had shown in 2021, which Dr. Srinivas had just shown to you. And this was our experience in the chelation therapy in Wilson's disease in the Journal of Hepatobiliary Sciences. A significant note is made that we've been a part of the clinical practice guidelines, the Indian practice guidelines, and here under the leadership of Professor Dhiman, we could form these guidelines. This is the Indian National Association of the Study of Liver, the Indian Society of Pediatric Gastroenterology, Hepatology, and Nutrition, and the Movement Disorder Society of India have all three come together and published our guidelines. What is the dent we have made and what is different compared to other guidelines is that there used to be a modified Leipzig score that was in place for diagnosis of Wilson's disease, which was very restrictive. It had a lot of weightage given to mutational analysis, and some redundant tests, which we've done away with, included a few clinical and historical corroborative evidences. And so this diagnosis now is much more easier. We've given higher points to those patients who have ceruloplasmin in single-digit value. The other good thing about this paper is that we've realized from the National Institute of Nutrition, the copper content in the Indian diet is not as high as that of the West. So even our red meat as well as the legumes, except for the red gram, do not contain very high copper. But obviously there are no formal studies in India to look at the same, so it's premature to talk about it. But there are items which have low copper content and some which have high copper content. This is a new concept and which is called the exchangeable copper. And this is that normally copper is distributed in our body in the form of transcuprin and ceruloplasmin majorly, which is strongly bound and it is not chelatable. And these are very heavy particles. A smaller amount of copper, which is albumin and peptide and amino acid bound, is very labile for chelation. And this is called as the exchangeable copper. Earlier, this was known as the non-ceruloplasmin copper, but non-ceruloplasmin copper was a mathematical equation. This is a direct assessment. Free copper is the best copper to actually is the one that is very, very toxic, but that is an ultrafiltrate copper. It is unstable for estimation. So short of that, the exchangeable copper tells us a lot. So already in neurological Wilson's disease, it had been shown that for the diagnosis as well as for the severity of prediction of neurological disease, this exchangeable copper is slowly coming into vogue. So what we did was we thought maybe the exchangeable copper will also help in assessing the adequacy of chelation for our hepatic Wilson's disease patients. So normally our adequacy of chelation is assessed by 24-hour urine copper, serum copper, non-ceruloplasmin copper, and liver functions. But none of these are gold standard, all have fallacies in interpretation, and there are a lot of difficulties. So we thought we'll use exchangeable copper. This is by applying a filter which filtrates all particles which are above 30,000 Daltons, and it generally estimates the albumin bound, peptide bound, and the free copper. And ratio, which is the relative exchangeable copper, which is exchangeable copper by the total serum copper into 100, gives us a estimate. So with doing all this, we presented a paper which is an abstract, and this is exchangeable copper, whether it is a better prognostic tool for assessing treatment control in hepatic Wilson's disease. And this was judged as the best abstract in an international conference. And about 61 patients or follow-up patients of Wilson's disease. And just in a gist, I would like to tell you that of all the parameters that we studied, only exchangeable copper significantly differentiated between the stable and the unstable liver disease, giving some hope to this new modality. And exchangeable copper, the new chelators require the levels to come down to more than 0.9 micromoles per liter. And thereafter, if you have to achieve liver stability, it should always be less than 0.87. So the advantage we have with this exchangeable copper is that it gives us about 22% advantage over the regular modalities of assessment of chelation. The second part of the paper, we looked at new recently diagnosed Wilson's disease and whether we can predict their survival using the same. And this was an oral presentation in the very prestigious American Association of the Study of Liver annual meeting. And we could show in 31 new Wilson's disease cases that the exchangeable copper was significantly higher in the non-survivors as compared to the survivors, telling us that the toxic copper load is higher in these groups. And it also showed a very good area under the curve of 84% with a good sensitivity and specificity. And we found a cutoff level that may predict whether the patient will have mortality or not. So what are the recent advances and what does future hold for us? In terms of diagnosis, the PET64 copper is the one that will help us look at the copper load, MR spectroscopy for early neurological damage, and anterior segment optical coherence tomography, which is a better way of looking at the Kayser-Fleischer ring. People have started doing ATP7B protein for screening, and of course, exchangeable copper, which we've already started in our department. In terms of therapy, for a long time, the tetrathiomolybdate you've been hearing is in phase 3 trials in the neurological Wilson's. Methanobactrin is a drug, a chelator, which is used in animal models now. It's still not there in humans. And gene therapy and cell therapy are probably the things that are in pipeline in the future, there may be some hope for this disease. So in conclusion, Wilson's disease is challenging, but it is very rewarding to treat, at least the hepatic part. Multi-speciality participation is there in the holistic management of this disease. As you can see, we've shown that the overlap of disease manifestation is there with the chelator side effects. And if we have proper vigilance and monitoring during follow-up, we have a long way to go. And there are new dimensions for research to explore in this field, and I would invite everyone to suggest us how we can take research further in this field. So I'd like to thank everybody for this presentation. And Wilson's disease is not just my disease or your disease, it's everyone's disease. And over time, these are the departments who have significantly helped us in managing these cases. A special mention to the Department of Neurology, Hematology, Endocrinology, and Nephrology, who've helped us manage these cases through all the adversities that we've faced so far. So I thank you on behalf of the department, and especially thank you on behalf of all the patients for patiently listening to us. Thank you.